I would like to thank all the people who are sharing for such an activity. We start our monthly scientific activity. We restart our activities again this year. I'm honored to be the head of the anesthesia department. We start with obstetric anesthesia. Usually we rely on our professors and our colleagues from Qasr Al Aini University, but this time we are happy that Professor Dr. Gamal Lotfy from Al Azhar, Professor of Anesthesia and Intensive Care from Al Azhar University and Nasr Institute University, is going to share his experience. We are open-minded. We have to expand the knowledge from everywhere in the country, even from everywhere of the world. So I would like to thank Dr. Asmat Abu Rigal and Dr. Magid Salah and Dr. Nassine Rifai for their great effort in organizing such activity. And I'll keep the phone for Dr. Asmat to start this scientific activity. And thank you.
Thank you, Dr. Mohammed Abdul Raouf. We are honored that you start our scientific day. Thank you for your support. I'm Dr. Ismat, the head of anesthesia of OB-GYN University. I would like to thank all my colleagues who shared in the delivery of this event. Actually, while organizing this webinar, especially the interactive session, the three doctors, Dr. May, Dr. Alia, Dr. Fahim, were very active and even proactive to search in references and to bench our work with what has happened and reviewed internationally about Marfan syndrome in cesarean section. They were very patient to review and add and omit from the slides. Together, I thank them for their patience and their of course, effort. Another thing, I would extend many thanks to Professor Dr. Nesreen. She is always supporting the obstetric and the gynae department, anesthesia department in Qasr Al Aini Hospital. And I would like to extend also my thanks for lecturer Dr. Samir for helping with us. And keeping the best for the last, finally, we are honored to have with us today Professor Dr. Gamal, who will be sharing with us tonight with a very important nice lecture. We are honored for him to share us. So I will be glad to moderate and introduce our speakers. And we will start by Professor Dr. Gamal Lotfy, Professor of Anesthesia and Intensive Care and Pain Management at Al Azhar University. He is the head of Intensive Care Unit at Al Azhar University Hospital. And he's a consultant of anesthesia and intensive care at Nasr Institute Hospital. He is going to tell us today a very nice lecture about anesthetic implication of hysteroscopy. So, Professor Gamal, please, you can start.
First of all, I would like to thank my dear colleagues and dear Professor Dr. Mohammed Abdul Raouf, the head of the anesthesia department and ICU at Qasr Al Aini, and Professor Dr. Magid Salah, Professor of Anesthesia and Intensive Care and Pain Management at Qasr Al Aini Hospital, and Professor Dr. Nesreen Rifai, Professor of Anesthesia and ICU Pain Management at Qasr Al Aini. I would like to thank the Professor Dr. Asmat Hijazi, the organizer of this meeting. I am a great pleasure to be here and my colleagues and professor in Qasr Al Aini University. My topics today, we start the anesthetic implication of hysteroscopy. I will try to cover this point, the incidence, the classification, and the complication of the hysteroscope. What is about the distending median, the mechanical factor, and the effect of electrocauterization, anesthetic complication, early and late complications. Bentonelli has the first man who discovered the visualization of the uterus since 1869. It is minimal invasive technique, diagnostic and therapeutic approach for It is consist hysteroscope of viewing system for illumination and endoscopy, and distending medium for the visualization, and another instrument for aspiration and the removal of the septum or polyp. This is a picture of the hysteroscope, as we mentioned, is illumination system and the distending medium and another instrument for the removal of the polyp or the septum or adhesion. What is the types and the indication of the hysteroscope? First of all, it is diagnostic for unexplained vaginal bleeding and localization the site of the missed intrauterine device, investigation the causes of abortion and infertility, surgical hysteroscope for the removal of endometrial ablation, excision of the polyp or fibroid, removal of the septum, and adhesion. A choice of anesthesia for the hysteroscope depends on the patient preference. If the patient refuses regional anesthesia, can get the general anesthesia. The length of operation for the short diagnostic procedure, it needs a simple technique. If laparoscopic accompanied by hysteroscope, we need long term of anesthesia, general anesthesia with intermittent post-pressure ventilation and muscle relaxant, day case surgery or day surgery, and the medical fitness of the patient can determine the types of anesthesia. Types of anesthesia for hysteroscope from the general anesthesia. As we mentioned, for short diagnostic or outpatient, we use propofol, oxygen nitrous oxide, and inhalation anesthetics, short acting. And we use total intravenous anesthesia with propofol infusion, face mask with laryngeal mask for the diagnostic and simple procedure. But for surgical hysteroscope, we need general anesthesia with endotracheal intubation and post-pressure ventilation with full monitoring and muscle relaxation. Types of anesthesia on regional anesthesia, either neuroaxial anesthesia, spinal or epidural anesthesia. Sensory level should be up to T10 for adequate anesthesia. The advantage of regional anesthesia, the avoidance of post-operative nausea and vomiting. In addition, local anesthesia may be paracervical or intracervical block, or topical anesthesia of the uterus or simple infiltration may be sufficient for the short-term procedures. What is the complication of the hysteroscope? What is the main issue in these topics? Complication related to the patient position, complication towards the vasovagal attack from severe pain, anesthetic complication, the complication related to the endometrial axis or cervical trauma, uterine perforation, intraoperative bleeding, terminal injury, gas or air embolism, which is fatal in such situation, and the problem of distending medium and the fluid overload. Post-operative complication of hysteroscope started from the early post-operative, from infection and post-operative bleeding, or late complication from persistent complaint or intrauterine adhesion or hematometria, or uterine rupture in subsequent or the following pregnancy. What is the complication of hysteroscope can be summarized according to the ABC. A or air embolism, B bleeding and perforation, C cerebral edema from the dilutional hyponatremia, and this E electrolytes imbalance, the most important dilutional hyponatremia, fluid overloaded from hysteroscope syndrome, I will discuss later on. Gynecologic and obstetric complication from the bleeding and infection and hematometry. Again, this is the complication most common: perforation, bleeding, fluid overload, infection, and hematometry. Patient position, it is very important issue during the hysteroscope. Lysotomy position carry much risk for the nerve injury. Modified lysotomy position, it is ideal position. just moderate hip flexion with limited abduction and external rotation. It is very suitable in such situation. Incorrect position carry the risk for the nerve injury, as we mentioned, back injury or back pain or damage to the soft tissue. What is important, the compartmental syndrome of the lower limb and deep vein thrombosis DVT, which is a serious situation. This is a nerve which can be affected during the abnormal position started from the sciatic nerve, femoral, obturator, peroneal, or saphenous nerve. The compartmental syndrome in the lower limb as wrong position. It is a pressure on the muscles of the osteofascial compartment lead to ischemia and later on the reperfusion injury. The sequence will be the rhabdomyolysis, permanent stability of these muscles. This event it is facilitated by leg holder and the pneumatic compression of stocking or any direct pressure to the lower limb during the procedure, especially for a long time. The risk reduction and how to manage these problems, you have to stick to ideal isotomy position, moderate flexion with limited reduction and external rotation, limited abduction and external rotation. You have to avoid push pressure in the prone area. You have to avoid leaning on the side of the patient during the procedure, which is a serious complication. Early identification and management of this compartmental syndrome. Distending medium and the problem of the complication of distension medium. Distension media or distending media, it's either liquid or gas carbon dioxide or liquid. You can classify it into high molecular weight distending medium, dextran 32%, or low molecular weight, either classified to electrolyte and non-electrolyte. Electrolyte is normal saline or ringer lactate, or non-electrolyte glycine 1.5%, sorbitol 3%, mannitol, and dextrose. Low viscosity media, which is electrolyte free, as we mentioned, glycine, sorbitol, mannitol, glucose 5%. It is used in diagnostic hysteroscope, used in operative hysteroscope using mechanical. We can use monopolar resectoscope or cauterization. Low molecular weight glycine. Glycine, it is inhibitory neurotransmitter in the brain. It is a simple amino acid that mixed in water and supplied in 1/2 liter of bag. The advantage, it is non-electrolytic, hypoosmolar osmolarity, it is about 200 millimole per liter, non-hemolytic and non-immunogenic. The intravascular absorption syndrome occurs with the high low molecular weight distending medium, mainly glycine, more in premenopausal woman. Why? Because the female sex steroid hormone, it is inhibits sodium potassium ATPase pump with water and sodium not throughout of the cells and lead to the brain edema. Gonadotrophic hormone agonist inhibits such hormone action, may prevent this complication to be occur. High viscosity medium complication started from the allergic reaction, non-cardiogenic pulmonary edema, high output left ventricular failure, coagulopathy, impaired platelets function, hemodilution of fibrinogen, decrease factor 5, factor 8, and factor 9. Low viscosity medium will lead to the most serious complication of what's called Hysteroscopy syndrome. Hysteroscopy syndrome, the component is volume overload, hyponatremia, hyperglycinemia, hyperammonemia, and hypothermia. Manifestation of the hyponatremia according to the serum sodium, which is very serious complication due to the absorption of the hypotonic solution. Serum sodium 120, it manifested the cardiovascular or CNS manifestation. The cardiovascular widening of the QRS complex or CNS restlessness and confusion. of the serum sodium 115, widening of the QRS complex and raised ST segment, nausea and soreness, disturbed level consciousness. If the serum sodium below 110 will develop ventricular tachycardia and ventricular fibrillation, later on seizures, convulsion, and coma. What is the glycine? Intravasation of glycine, what is happening? Glycine, when intra-absorbed intravascular, produce the volume overload. Volume overload lead to the hyponatremia. Hyponatremia lead to hypoosmolarity. Hypoosmolarity lead to the cerebral edema. At the same time, the volume overload to hypertension. In addition to the hypoosmolarity, produce left ventricular failure and pulmonary edema. Hypoosmolarity lead to the hemolysis, the rupture of RBCs, and anemia. Glycine, also hyperglycemia, metabolized into ammonia, lead to hyperammonemia. Hyperammonemia lead to encephalopathy, and lead to confusion, nausea, and vomiting, and coma. What is the hyperglycemia? Hyperglycemia, as we mentioned, glycine, it is neurotransmitter in the brain, similar to GABA in the brain, spinal cord, the retina. Benzodiazepine used for treatment convulsion through activation of retina GABA receptor may be compromised vision. So the glycine increase the effect of N-methyl aspartate excitatory transmitter and lead to encephalopathy and seizures in such patients. Hyperglycemia, magnesium exert a negative control in N-methyl aspartate, so hypomagnesemia in addition to hemodilution will lead to increased convulsion or seizures. So magnesium and ketamine are NMDA antagonists, thus may be tried for the treatment seizures or convulsion caused by hyperglycemia. Hysteroscopic syndrome, what is the definition? It is intravascular absorption of hypotonic irrigation fluid with subsequent hypotonic hypervolemia and hyponatremia. This syndrome, it is similar to URB syndrome in men, which physiologists recognize the problem of intravascular fluid absorption as URB in men. Hysteroscopy is similar to the URB. Two routes of fluid absorption in the intravascular volume through the endometrial vein or through the fallopian tube. The endometrial vein through the high pressure route of absorption due to the intrauterine pressure. It is more than the mean arterial blood pressure, or the low pressure from the open the blood vessels during the resectoscopy. What is the factor affecting the absorption and hysteroscope syndrome? In TURB, the hydrostatic pressure at prostatic bed, it is reported to about 70 millimeter mercury. The duration of surgery should be limited to 1 hour and size of the prostate. But in the hysteroscope, the level of intrauterine pressure, we know that the uterus, it is non-compliance. When the flow of the fluid or irrigation fluid, the pressure may reach about 7 to 100 millimeter mercury. The level of mean arterial blood pressure, the patency of outflow challenge during the distending medium, the penetration of the uterine or instrumentation or the opening of many sinuses or vessels. How to limit the severity of the intravascular syndrome? You have the depend on the amount of fluid absorbed. As much the fluid absorbed, it is the syndrome will be developed. Later on, the number of the vascular open sinuses, the duration of procedure. If the duration of the procedure extended, the syndrome will be occur. The flow pressure, it can be present intra and post-operative. Intravascular absorption syndrome can occur during intraoperative or immediately post-op. This figure shows the circulatory absorption create a pressure gradient between the blood and the brain cells. As we mentioned, the brain cells, This can be overcome by pumping action out the cells in the blood through the sodium-potassium ATPase, but women brain deficient in such mechanism, so the water will be retained inside the brain cells and produce cerebral edema. How to prevent the gonadotrophic decrease the volume systemic absorption distending medium, dilution of vasopressin immediate before cervical dilatation, 8 ml or 4.21 ml of vasopressin deeply injected at 4 and 8 o'clock in the cervix will be decrease the absorption of the fluid during procedure. Intraoperative fluid management problem. Before the resectoscope, we have to take baseline serum electrolytes sodium and potassium. Women with cardiopulmonary disease should be evaluated carefully for the fluid balance for the shift of the fluid volume, operating usually at the lowest effective intrauterine pressure. Pressure should be from 50 to 80 millimeter mercury, always to try to keep the intrauterine pressure below the mean arterial blood pressure in order to decrease the intravascular absorption of the fluid. Completing the procedure as quickly as possible, you have to measure the fluid inflow and fluid outflow in closed system, precise the calculation of absorbed fluid. You have to use the bulk vaporizing electrode, which reduce the systemic absorption compared to the section blue. It is more greater coagulation, more greater collateral sealing of the vessels. Deficit of the fluid should be calculated. If the deficit reaches the predetermined limits, depending on the patient baseline status, could be around 750 and to 1,500 ml. The serum electrolyte should be measured. We have give furosemide from 10 to 40 milligrams, depending on the renal function. You have to termination of the procedure of the serum sodium decrease below 125 milliequivalent to the liter, or if the deficit it is more than 1.5 and 2,000 milliliter of glycine. And if you use normal saline, the volume can be doubled in this situation. Normal saline 0.9% sodium, it is safest, widespread availability, low operative cost, physiological disposable by peritoneal absorption, but at the same time, excessive vascular absorption lead to fluid overloaded and pulmonary edema. It is not suitable for the monopolar. It is good conductor for the electrons. It has dispersion of the light, can use, but it is not suitable for the surgeon. It is more suitable for anesthetist, but not for the obstetrician. Gas embolization of the use the carbon dioxide as a distending medium. A lot of complication can be occur. Gas embolization, carbon dioxide or respiratory acidosis, arrhythmia, and cardiac arrest. Symptoms and signs start from the acute circulatory collapse, unexplained hypotension, tachycardia, and desaturation, Male-Weir murmur, and sudden increase intravenous pressure, abrupt decrease of the end-tidal carbon dioxide, and you can withdrawal of the air from the central venous pressure if you apply preoperative. The treatment management stop the procedure, stop use of the nitrous oxide. We give 100% oxygen. We change the patient left lateral position into Trendelenburg position and try for aspiration of the gas, which it is fetal condition if it is occur. Precaution to prevent carbon dioxide or air embolization. You have to avoid Trendelenburg position. Remove last dilator just before inserting the resectoscope. Minimize the cervical trauma. Limit repeated removal and reinsertion of the resectoscope. Maintaining the intrauterine pressure below 100 millimeters mercury and the flow rate below 100 liters per minute. The assistant must keep a watch on the fluid bottles and inform surgeon before changing it to prevent any bubbles on the uterus with care. Vaporizing myoma limits the need to remove the fibroid clip. The injection of intracervical vasopressin block gas from entry into the circulation. What is the management of the carbon dioxide or air embolization? It is okay. With head low position with Trenberg position, 100% oxygen, insertion of central venous catheter, and trial to withdrawal of the air, and may require cardiopulmonary resuscitation. Anesthetic consideration for hysteroscope, preoperative assessment, history examination very beneficial. Choice of anesthesia, monitoring, standard ECG, blood pressure, Untitled pulse oximeter, CVB, especially for surgical hysteroscope and cardiac output, core temperature in the lengthy operation. Monitoring of the fluid, it is very important. Automated system or rough measurement is the inflow and outflow. Xenol tagged irrigation fluids, clinical assessment, pulse, blood pressure, and central venous pressure, laboratory hemoglobin, hematocrit, blood gases for respiratory acidosis, sodium for development of hyponatremia. Prevention of hysteroscopy syndrome. You have to limit the pressure to 6 to 70 millimeter mercury, never exceed 100. Limit the time to 1 hour. Regional anesthesia, it is better. Limit Trendelenburg position to minimum to avoid air embolization. Electrosurgical hysteroscopy with physiological medium, it is very important. General guideline consideration during the hysteroscope. 500 ml deficit, you have to measure serum electrolytes. 1,000 liter deficit, 1,000 milliliter deficit, furosemide, give furosemide intravisa and check sodium potassium again. 2,000 milliliter deficit, you have to stop surgery and suspect hyponatremia and aggressive management if it is occur. Treatment of the hysteroscope syndrome, you have to stop surgery, furosemide, 20 milligram intravenous oxygen. Treatment of the pulmonary edema developed by intubation into tracheal tube, post-pressure ventilation with PEEP, invasive blood pressure monitoring and central venous pressure, arterial blood gases for management of respiratory or metabolic event, and serum sodium. Treatment of the sodium correction of the hyponatremia developed. The important to correct sodium deficit, it is equal to total body weight multiplying 1/4, multiplying 125 minus present sodium. According to the symptoms, mild symptoms, you can correct the serum sodium 0.5 milliequivalent per liter per hour. If the patient with developed severe moderate symptoms, you can correct up to 1 milliequivalent per liter per hour. Severe symptoms, you can correct up to 1.5 milliequivalent per liter per hour. In severe cases of the hyponatremia, serum sodium less than 120 and severe cardiovascular and neurological manifestation, hypertonic saline, it is indicated. We start 100 ml per hour. A rapid correction of the hyponatremia can produce serious complications in central pontine demyelination. Again, if the patient develops convulsion, you have to give anti-convulsion and diazepam or benzodiazepine barbiturate. Ketamine, dexmedetomidine, alpha-2 agonist inhibit N-methyl D-aspartate receptor, and you have to suggest in the treatment of convulsion. Blood transfusion for anemia from the hemolysis RBCs as a result of the hypotonic irrigation fluid. Conclusion, hysteroscope surgery, it is safe and effective, specific risk due to distension media and surgical technology use. Most new technologies avoid the use of non-ionic distension medium, and hence many of the complication, it is the fluid overload. To minimize the risk of complication, appropriate case selection, recognition of the learning phase. The operator should be learned and diagnostic for 500 cases before the operating hysteroscope. Patient with surgical team operations, knowledge the distension medium, what is the low viscosity and high viscosity and the complication, knowledge the hysteroscope equipment use. The surgeon skill remains the best safety measure in the operative hysteroscope. Thank you very much.
Thank you, Dr. Gamal, for this very informative lecture. And we can now open the field for questions and answers. 5 minutes, please.
Dr. Asmat, can I add a comment, please?
Of course. We are honored.
It's very common. The following discussion occur between the surgeon and anesthesiologist. Usually the surgeon is senior and the anesthesiologist sometimes junior. So the surgeon tell the procedure will take less than 2 minutes. You can give a patient a face mask. And some of our junior colleagues do hysteroscope using a face mask. So please, this is completely prohibited. And for any patients undergoing hysteroscope, he should be intubated and ventilated. It is a must because all of such complications, if happened, it's better to be managed with an intubated patient. And sometimes the surgeon give plenty amount of fluids and the patients enter into pulmonary edema. So this can be managed betterly with an intubation. So my message, it should be a clear message. Any hysteroscope patient should be intubated. Thank you.
Thank you, Dr. Mohammed, for your comment. And if anyone would like to have a question, we have 5 minutes for question, and Dr. Gamal and Dr. Mohammed will answer you. We were having 3 at least of the participants raising hands during the lecture. So now is the time for the questions, please. If anyone would like to have a question.
Ojo, you can talk. The first one, Dr. Ojo. Are you happy to talk?
Would you like to put your question in verbal, talking to us, or writing?
Okay. Dr. Wael, Dr. Walid, Dr. Wael. Dr. Walid. Dr. Walid, okay. So I think we will not need to waste the time.
Yeah, hello? Hello?
Yeah, hello?
Yeah, I just have a concern regarding our colleague recommendation about, I think he was saying that for all hysteroscopies, it should be endotracheal intubation, but I believe if it's just the diagnostic hysteroscopy, there is no need for intubation.
I would like to recommend on him again, even if it's diagnostic, even if it's a very short procedure, from the safety point of view, we should intubate every patient. This is my opinion. And again, I'm dealing with a lot of stuff. If this is your experience, you can do it yourself. But if you are talking about the whole department, this should be a must to intubate every patient for hysteroscope for the safety of the patient.
Yeah. What's your rationale for that, sir?
My rationale that even if it's diagnostic, you can get air embolism. So if air embolism happens and sudden cardiac arrest happened, it's better that the patient be intubated. You cannot say that air embolism will never happen. A lot of serious complications might happen. And again, surgeons don't, especially obstetricians, don't know the exact amount of fluid they are injecting. It's not like urologists. Urologists are a little bit more aware, but obstetricians usually less aware. So from the safety point of view, fluid overload is not uncommon even in minor diagnostic procedures.
If you don't
please,
want,
doctor.
just comment, Dr. Mohammed, if you don't want to intubate, we can give spinal anesthesia. That's the best. It's the same as TURP. So for spinal anesthesia, when the patient has spinal anesthesia, we can diagnose the syndrome early by dizziness and hallucinations and CNS disturbance.
Dr. Glycine, if you are giving spinal anesthesia, this is accepted. But I mean, if you are giving GA, general anesthesia,
you have to intubate, sure.
Okay.
I've seen a case in our university hospital when the patient developed severe pulmonary edema, hyponatremia, sodium was 97, which is incompatible with life, and severe ventricular arrhythmia within 15 minutes. When we reviewed the fluids used by the surgeon, he said only 9 bags, but the bag was 3 liters. So he used 27 liters under pressure, distilled water within 15 minutes. And the patient was about to arrest.
Dr. Gamal, please.
I have comment, Dr. Abdurraouf. I am agree that the procedure, the time of the operation can be determine the types of anesthesia. Regional anesthesia can be accepted, either spinal or epidural. If the patient it is accepted, it is very beneficial. You have to monitor patient; it's fully awake, and if it is having such mishap as ear or gas embolization, it will be occur and resuscitation at them. But for the prolonged and surgical hysteroscope, as you mentioned, you have to full controlled and general anesthesia with intratracheal intubation with beep for monitoring as well.
No, my point is, if you are giving general anesthesia, and even if the surgeon telling you it's a very short procedure, it's diagnostic, I'm insisting here that we have to intubate. If you are using regional anesthesia, this is accepted. But if you are using general anesthesia, my policy, you should intubate. This is for more safety.
Yes, I am agree 100% for the possibility of development of the intravascular absorption and pulmonary edema in the period.
Professor Dr. Tariq Abdelbari, do you have a comment? Dr. Tariq?
No, I tried to I let him to talk. Prof. Tariq, can you talk, please?
I think you can hear me now, right?
Yeah, I will hear you now. Yeah.
Okay. We have to differentiate between diagnostic procedures and therapeutic procedures. As for diagnostic procedure, this is just a few minutes procedure. And it's either done by using spinal anesthesia, which is the best for sure, or if we choose general anesthesia, laryngeal mask airway is more than enough for this short procedure. As for surgical hysteroscopy, definitely can be done under regional anesthesia because we have a time limit, and the time limit is 1 hour. So spinal or epidural will do the job. And the most important thing is that the fact that the anesthetist must be fully aware about the complications of the procedure and has to anticipate the complication before it occurs. So he has to keep an eye on in and out of the fluids, on the hemodynamics and everything, so in order to prevent the occurrence of the problem. If general anesthesia, it's okay, but I would rather prefer regional anesthesia, whether this is done under, whether the procedure is diagnostic or surgical. As for intubation, I personally do intubation if the patient refuses and it is a therapeutic. But I don't insert endotracheal tube for diagnostic procedure, and I don't give muscle relaxants for diagnostic procedure if it is under laryngeal mask. It's just a very simple procedure. It doesn't take long. It's just few minutes. So it's just 5 or 10 minutes. So if I'm going to give a muscle relaxer, I'm stuck with the patient for another half an hour for nothing. Thank you.
Thank you, Dr. Tariq. Any more question in this lecture, please?
Dr. Asmat, we have to put a consensus in our department that every patient to be intubated if we are going to use general anesthesia. Dr. Tariq Abdelbar has a great experience, so we cannot transfer his great experience to our junior staff. So it's our protocol. I think for the safety, we should intubate.
Then we can come a conclusion from all this that if we choose regional anesthesia, it's okay, but when complication arises, we can then treat after we intubate the patient. Or if we start from the beginning, as Dr. Professor Mohammed Abduraouf said, general, so it's better to be a tube, not LMA, for safety and for interaction to any complication that may arise. So thank you for all the opinions, and